Lovely. Okay. Well, thank you to Annette and Vicky for kindly inviting me. I think we met in November in 2022, and they've really kindly shared a real interest in the generation study, which didn't have a name back in November. But anyway, I'm here. My background is that I'm a nurse. I did my adult and then paediatric training, and then went into health visiting. And the opportunity for working in the sort of world of genomics really came my way when I was a research nurse for a community trust. And we were really privileged to be able to recruit some children and their families who were in the community for the 100,000 genome programme. And that just sort of whet my appetite really into the potential for genomics in healthcare today. So things have moved on a little bit, and I have had a secondment to Genomics England to work in their clinical team to really support the resources that we need to help provide for parents and families to explain the research study that I'm going to talk about, and then also to prepare the workforce. So, as Annette said, I've got a sort of an outline of what I think it would be good to cover today. Annette and Vicky really wanted me to tell you about what the generation study is, where and when it will take place, what the impact will really be for families and also for the workforce, the healthcare professionals. So I thought it would be good just to set the scene a little bit, to explain to you about Genomics England, and talk a little bit about current policy, because although you know, I don't want to get too bogged down in that, I think it is helpful to explain kind of the process that has meant that we've got to the point today where we are actually looking at sequencing the genomes of newborn babies, and kind of how that has shifted really to where we are today. Then I'm going to talk a little bit about the generation study, so hopefully that will give you a real flavour of it. Then I'm going to talk about the education and training and equipping the workforce that is really vital if we're going to do this well. And I'm going to mention a little bit about the evaluation, because obviously this is a big, well, I'll talk about it, but it's a big study and we need to evaluate it well. And I want to just end with a few thoughts about our roles really for today and tomorrow. And as Annette said, I've got some points in this presentation where hopefully anybody that wants to ask a question can. And I always say there are no silly questions, so please feel free, and hopefully we can have a bit of discussion. And if there's time at the end, I'd love to kind of hear your thoughts about the generation study, but also sort of thoughts that you may have about what you think could be really important for the sort of training and equipping of the workforce, because I think that's actually very helpful to hear and something that we're very invested in Genomics England. Okay, so a little bit about Genomics England. So it is a company that the Department of Health and Social Care actually own, and its really two purposes are to support an evolution, a sort of shift in using genomics in healthcare across the board, and also to accelerate genomic research, because we know that both of those are going to improve patient outcomes and that we need both. So it works very closely with the NHS to deliver that. So it can't do it on its own, it has to do it alongside and within the NHS. And then it also seeks to provide health data and technology to researchers who can use the genomic information that is stored, if you like, to hopefully start to piece together potential new treatments and medical discoveries. So a little bit about the background, which I mentioned. Professor Dame Sally Davies, who you may have heard of, was the Chief Medical Officer before Chris Whitty, and in her final Chief Medical Report, she called Generation Genome, which was back in 2017, she really pushed and promoted the potential for genomics to be used in newborn screening. So she said, you know, the opportunities now really exist for us to do that. And that was a sort of real sort of call for action. Then Genetic Alliance UK, which I'm sure many of you are aware of and perhaps work with, you know, a fantastic organisation in terms of promoting and advocating for families and children, patients with rare disease, talked about and really promoted the value of having a pilot to of genome sequencing for newborn screening. So that was, if you like, the sort of another endorsement being given. And then a task and finish group, which looked at the sort of genomic analysis for children, again gave its backing for this programme. So in a nutshell, what we're talking about from these three pieces of sort of policy, and there's a little bit more recently, is to use genomic sequencing to screen in the newborn phase, if you like, really early on in a baby's life, for potential genetic variants that could cause rare disease, which is different from what we currently are doing for newborn babies. So a couple more pieces of policy for you. The Genome UK, again, many of you may have heard about it. This is kind of the government's strategy to really extend genomic healthcare, and for the first time it really put a sort of steer, if you like, on genomic sequencing of newborns. And then finally, 2022, the Genome UK, that kind of drew attention, if you like, to Genomics England's work to promote this study. So it's kind of been a real push together, if you like, of policy, which has obviously been completely driven by the evidence to get to where we are today. So I'm sure many midwives on the call, and many of you will know what we currently offer, and it's called the newborn blood spot screening. It's a really efficient and effective service for all newborns, and we have a really high take-up in the UK. So about 97% of all babies will have this, and it tests for currently 9 conditions. So it looks for these conditions in babies. Some of them are metabolic, some of them aren't. Obviously, sickle cell is not, cystic fibrosis is not, hypothyroidism is not. The newborn blood spot screening is not going to stop. This is a universal service that is completely operational. The generation study, which is the study that I'm talking about, is a research study that's looking to test for conditions or genetic variants that could cause additional conditions. So it's not in any way replacing it. Both are running alongside each other, if you like. I think that's an important point to make, because that may be something that parents in particular want to know. So a little bit about the study then. Essentially, it's looking at sort of 3 components. And because it's research, there's no guarantee that this is going to kind of be rolled out at scale. This is what, we're looking to explore really. But essentially, it is looking to evaluate the usefulness, the potential of screening newborn babies for a larger number of genetic conditions that we see in early childhood using whole genome sequencing. Secondly, it wants to understand how, by having babies' genomic data in our research library, we can use that data to potentially develop new treatments and diagnostics for NHS patients. And finally, it wants to consider what the sort of potential risks, what the benefits are, what the bigger implications are of storing a baby's genome over their lifetime. So that's sort of 3 areas that we're looking at. I guess many of us are really aware of the kind of where we've got to in terms of the technology, the kind of cost implications, the potential of genome sequencing. But for anybody that perhaps isn't so sure about that, I think this slide just sort of shows really why we're talking about genome sequencing. So clearly it's the potential to pick up and detect disease-causing variants in one technology. It can respond really rapidly to the kind of latest scientific knowledge. It can be used in that sort of research environment, because once you've stored a baby or a patient's genome, that doesn't go away, that's stored forever. So it's about harnessing the kind of current technology and that being potentially useful across a patient's lifespan because their genome doesn't change. So I just wanted to share a little bit with you about the Generation Studies vision, and maybe I should just clarify that within Genomics England, the newborn genome programme has been in existence probably for the last couple of years, while all of this sort of the programme, if you like, has been defined and the budget has been established, and the kind of work to kind of get this to a point where we are today has been established. You can imagine that, you know, it is a big study, and we've had, because it's a research study, we've had to seek ethical approval, and all of that it has sort of gone on under the sort of umbrella, if you like, of the newborn genome programme. But the specific research study is called the Generation Study. So the Generation Study is the whole sequencing of newborns that I'm sort of talking about today, but I just thought it was important to clarify. So our vision is very much, as we've identified, the kind of exploring the benefits and challenges, practicalities of offering whole genome sequencing to newborns. But it's a bit broader than that. It's also about running and evaluating an ethical approved research study embedded in the NHS. Because ultimately we want to know, you know, is this kind of possible really, and how does that look? Alongside all of the sort of planning that's taken place, there's been a real commitment to co-production, which, you know, we know as nurses and midwives, healthcare professionals, it's really, really important, and to hear the sort of views of key stakeholders and members of the public. And that really has shaped a lot of the kind of understanding about how we do this and how we do it well. And I, just as an example, all of the sort of content that we've prepared for our parents and families and has really been sort of looked at by potential participants to really help us understand what they think is important, and that's sort of ongoing. Then we also want to consider the impact on NHS clinical care, and really particularly on the workforce. And that's a really key aspect of our understanding, because everybody is very aware of minimising the burden on staff, but also making strides to improve the services that we offer. And finally, to ensure that our work is human-centred, it's ethical, it's translatable into a clinical service if the evidence supports that. So I thought I'd just share with you the sort of key numbers, because I think this is sort of helpful and hopefully visual. So what we know is that every day about 9 babies are born in the UK with a rare treatable genetic disease, where actually knowing early about that genetic disease really makes a difference. And often for babies and young children, they have a really lengthy diagnostic odyssey because they can't tell us. They may present with symptoms that are quite sort of vague, and it may take a really long time to establish what the cause of their symptoms are. We're expecting that we will need to analyse 100,000 babies, and the period is going to be about 2 years to do that. We know that there are about 600,000 babies born in England every year, so we know that's quite a large figure that we're going to be needing to recruit. And of those 100,000 babies that we hope to recruit, we are only expecting to see positive results for about 1,000. I'll come back to the kind of positive results, because we're actually trying to sort of move away from describing those results as positives, because it can be quite confusing. But essentially, we're talking about 500 to 1,000 babies for whom we find genetic variant that is likely to be causing a rare condition. I just want to come on to the design of the Generation Study. So I mentioned the sort of co-design element, but what I really like about this slide is, and I think it's something that we should all be really proud about, is that actually nurses and midwives have been really integral to the kind of Generation Study design. So, for example, there is a really well thought out, rigorous process that we have adopted for establishing the conditions, which I'll return to, that we will screen for. So you can imagine there are actually hundreds of conditions that we could be screening for, and we can't do all of that. But nurses have been part of that kind of group to establish what conditions we should be using and the kind of principles for looking at those looking at those conditions. Secondly, the how and the where and the when. So again, the nursing and midwifery workforce, alongside other healthcare professionals, have really been integral into how we do this. And then also the process of asking parents for their consent. So the sort of talking to potential participants when they're pregnant, answering questions, receiving their consent, that whole sort of how that might look, and key points when we could ask parents to consider joining the study, has been very much shaped by feedback from nurses and midwives. And this time last year, we were doing a smallish research study called the Baby and Mum Sample Study, and that looked very closely at what were the best ways to capture and to take a sample, and when, to ensure that we got the kind of best result possible for genomic sequencing. So again, we had certain midwifery units in London and Liverpool that were helping us to do that. And then finally, point number 5 is how we establish sort of returning results. So you can imagine, parents are obviously going to want results as soon as possible, and we have kind of continued to work quite hard to think about how we do that best. At the point we're at now is to make sure that the returning a result where there is a condition suspected is really, really watertight, and really sort of considering not only the parental needs, but how that is then rolled out into a sort of service that clinicians can also support. So I shall move on. I think a question that a lot of people want to know is, okay, so where and when? And I can't give you all of those answers, I'm afraid. I can give you the when, but I can't give you all of the where. So the rollout that we're going to do is going to be slow to begin with, and then kind of scale up. And the reason for that is that we want to make sure that it's manageable and working. So start small and slowly, and then kind of ramp up, so that ultimately we're probably going to have about 25 to 30 hospital trusts throughout the study, but it will probably start with 6 to begin with. And some of my colleagues in Genomics England are sort of involved in the operational side of that. So there are, many trusts that we're talking to, Cambridge being one currently. So I would suggest in your GMSA, it's really, really likely that a number of your hospital trusts are going to be part of this, the generation study, which will be amazing. Some of the factors that we've thought about for participating hospital trusts is the kind of birth volumes. We've also thought about and wanting to include hospital trusts that cover a number of populations. So we really do want this to be a research study in which diversity is captured, so that every family and child, if you like, within hospital trusts have that potential to join this research. And then we've also thought a little bit about, particularly for perhaps the start of this study and getting it right, where hospital trusts have got quite experienced research midwives and have done quite a lot of research already. That's been quite a sort of strong indicator in kind of early working together, just because that does probably make it a lot easier to start sort of to deliver this, and for us as an organisation to learn from and sort of see, if there are, where the pitfalls are and where the kind of pain points are. I'm going to come on just to talk a little bit about the conditions. So it clearly is a real challenge to sort of select, if you like, conditions that occur early in childhood, for which knowing early is going to make a difference, because there are so many. So what's happened is there have been a number of working groups, but one in particular that has really whittled down the principles that we need to be choosing to select those conditions. And this has been quite a sort of new approach, really. So we kind of deduced it, if you like, to 4 overall principles. And from these 4 principles, what's then happened is all conditions, of which there are, I think, nearly 1,000, have sort of been put into the pot, and they've been worked through about, well, does that condition meet the principles, and I'll go through those principles so that we can sort of reduce it to a point where, again, it's very much the sort of national clinical group that is deciding. So that's sort of within the NHS ultimately is deciding which of the conditions we will be selecting. So again, 4 principles. Principle A is that we include the genetic variant if there is strong evidence that that variant causes a condition and can be reliably detected. So obviously we need to be sure that we're going to pick up and not give sort of false information to families. Secondly, that we include the genetic variant if a high proportion of individuals or babies who have that genetic variant would be expected to have symptoms which would have a debilitating effect on their quality of life if we left it undiagnosed. Thirdly, that we include if early or pre-symptomatic intervention for the condition has been shown to lead to a real improvement in outcomes for children. Finally, that we include if the conditions screened for are those for which interventions can be offered equitably across the country. So, there's a real commitment to recognising that for some conditions, we have very specialist centres, and that may mean that not everybody can access it or that there isn't more difficulty. So it has to be equitable to be included. So this slide, and I know it's a bit of a busy one, but I just want to sort of share it. Don't feel you have to take it all in, but basically it's a slide that we're using quite a lot to sort of share the participant experience. So at the top in the black is, if you like, the kind of journey that a mum will make, when I'm talking about a mother who's pregnant, a birthing person, will make across the kind of journey, if you like, during the generation study. Obviously, there may be get out points for some of them. Some people may, not wish to participate. Others may wish to participate and then withdraw, for example. But anyway, across the black is the kind of journey. Across the bottom, if you like, the blue and the pink just sort of delineates what bits are going to be Genomics England work and what bits are going to be NHS work. So here you can see that there's definitely a sort of pathway, a journey for that pregnant person. So initially, it's going to be very much midwifery led, enabling pregnant birthing people to sort of hear about the study. We're talking about the sort of passive awareness early in pregnancy, and then hopefully sort of starting to share a little bit more information by sort of leaflets, by posters, having conversations to get to a point where somebody is in a position to either decide, yes, they would like to enrol for the study and consent or not. If they do choose to consent, obviously consent is a sort of an active process. You can, stop and start, withdraw at any point. But if they do consent, then at birth, we would be taking that cord blood sample. What's changed on here, which has not been adjusted yet because it's quite new, is that we are no longer taking saliva samples. So it is just going to be cord blood or capillary blood. Then there will be a period of waiting. And really that's where Genomics England is going to step in, because they're going to be organising all the sort of testing and the sequencing and the interpreting of those reports for that individual baby. Then that family will receive a result, and I'll come on to that in a minute. And depending on that result will depend upon what next, really, whether they will need to receive any care, but all will be, as part of their journey through the generation study, able to receive updates and be invited very much to sort of share experiences. So, we talked about wanting to hear from participants and the workforce kind of what being part of this study is all about. And then, of course, being a research study, there is the opportunity for a family or a person to withdraw at any point. So I mentioned the sort of potential results. So based on whole genome sequencing and the conditions that we are looking for, a family will receive one of two results. We're trying to avoid the use of positive and negative results because it is really confusing. So we're talking about either that somebody receives information to say that they have a condition, their baby has a condition that's suspected, or that they receive information to say that no conditions are suspected. There may be some, and we don't yet know how many, for whom we fail to get a sample. That might be because we haven't got enough cord blood. It might be because the sample isn't of a good enough quality. We don't yet know, but we have to sort of factor that in, and we will be explaining that to parents obviously as well, because we recognise that could be a really disappointing feature, and we hope it won't affect many. If a child is considered to have a condition, then this is the care and treatment pathway that we are talking about. Genomics England will highlight that there's a positive screen finding. At that point, they will be referred to a specialist, and the specialist will contact the parents. It is likely that that will then require further confirmatory testing, because remember, what we are doing so far is a screening test that is going to indicate whether there is a strong possibility of a condition, but we will need a confirmatory test to conclude that. Based on that confirmatory test, that will then define that child's clinical pathway. So very much part, as I've said, is, this sort of consideration that we can't keep any child, we can't lose any children, they must be visible, and we must make sure that we have adequate steps in place to ensure that they, if they have a condition suspected, are cared for. And for those who don't have a condition suspected, that actually we all understand what that means. That doesn't mean that child is never going to get sick. Doesn't mean that they may never need healthcare. We have to be careful about how we sort of explain findings. So in summary, what we can offer to communicate with all participants is that they will have a result, that they will receive updates about the generation study via a regular newsletter. There may be groups like sort of Facebook groups established, and we will be able to respond to their own participant particular queries. They may be invited to take part in further research, but that will be very much voluntary. And all children who at birth obviously have their genome sequence, when they turn 18, will be contacted and asked whether they would like to remain within the generation study, as in their genome continue to be stored for research purposes. It will be possible for participants to be contacted in the really rare event that by having their genome stored, a researcher finds something that's really relevant to their health, and we call that, as I'm sure you're aware, incidental finding. What we can't do, and we need to clarify this obviously, and we'll do with participants, is that we can't let them know each time their data has been used. That just isn't physically possible. We can't tell a participant about every variant in their genome, and as somebody said, we're not talking about sort of potentially adult conditions, and we won't be able to put a researcher in direct contact with a participant. Just going to show you this screen, and it just really highlights, I suppose, the multitude, if you like, and will include us all, I think, on this call, who may be sort of involved in the kind of pathway and network for a newborn baby and their family. And so I think what this conveys is that this is not only a big research study in terms of numbers, but actually the kind of impact at community level, perhaps patient support groups, for example, our own sort of healthcare professional background we're all going to be potentially affected. And I'll kind of come back to that at the end. So I'll just whistle through, but I mean, hopefully this is sort of reassuring you really that care and consideration is really being put into how to equip the workforce. And the way that we've done that is that another working group has been working alongside sort of people who've got a lot of expertise in delivering education and training in genomics. So, for example, the Genomic Education Programme, formerly HEE, have been really helpful. And basically what we've kind of concluded is that we need to identify competencies and sort of plan our training, if you like, based on competencies that we think people need to deliver the generation study. So currently we are working on how we, if you like, integrate what we know we need people to be able to do into sort of training. And a really important aspect of this, and I'm only giving one slide to it, which is, it doesn't convey how important it is, but clearly we really need to be able to evaluate this. So not only how feasible and acceptable it is, but also what's the uptake. Are parents interested? Are they kind of happy to go for this? Is it cost effective? What is the impact, positive and negative, on the wider system, on the NHS, and what are the kind of experiences and attitudes? So we'll be looking for those across, from parental feedback to a healthcare professional feedback. So there's many levels to this evaluation, but just to reassure really that it's going to be very thorough and rigorous. There'll be some sort of internal data that we'll be able to sort of receive, obviously, but there's going to be a whole sort of external evaluation to make sure that that's obviously as objective and transparent as possible as well. Just a few dates for you. So we have now got ethical approval. In the next few weeks, I think the first NHS trust that we will be working with will be confirmed. Later this summer, I think the date is early September, we will be publishing a list of conditions that babies will be tested for. And then hopefully by the end of this year, so November, December time, we will be hopefully recruiting our first baby. And then there is funding until April 2025 to run the study and hopefully obtain the 100,000 babies that we need for our study. So what are the endpoints? Hopefully we'll have sequenced the genomes of up to 100,000 babies. Hopefully we will have established an evidence base of what screening for those babies means, future treatment and research with newborns. And finally, we will have provided the data needed to evaluate the research study's outcomes and to inform future policy. And that's clearly massive, and that's not something that Genomics England is going to be able to sort of decide. That's going to be a kind of government decision. So just finally, really, a few thoughts from me about nurses. Clearly, and this quote is taken from this year's International Nursing Day, and it was their sort of press release. So together our future depends on every nurse, every voice, to not only be on the front lines of care, but also on the front lines of change. And I think, genomics, we talked about this sort of evolving into healthcare, it's clearly kind of where we're at. So my encouragement is that, to be involved. And I suppose I'm speaking as a health visitor. Many of you are probably very actively involved because you're, already in a role that where you're using it. I think also just to encourage you that actually many opportunities exist to be involved in the generation study, and there are some kind of roles that are being developed to support within the GMSAs to support this. So it may be that you sort of want to take this a bit further. And finally, I just want to encourage you to be aspirational for yourself and to be committed and to be visible, because I think so often, we are the people that are closest to the children and families and the patients. And so actually we sort of can advocate for them and, be involved in the kind of feedback that we really need to evaluate this. Yeah.
So, well, we've come to the end of our hour and we've gone over by 3 minutes. So if there's any other questions, please either email them to me and I'm sure Sally will get back to me. And also please send any requests for future Lunch and Learn Genomics sessions. I think we're starting to plan the autumn ones, because we're having August off, and having August off from the newsletter as well, because a lot of people are on holiday. So we're looking at what are we doing? Lunch and Learn, perhaps on the Genomics directory, maybe one on R21, prenatal exome testing, maybe cancer genomics. So anything else that you're interested in, let us know and we can pull something together. Is there anything you'd like to add? Anybody? Jo, Sally, Vicky?
Sorry, Annette, I was just going to sort of say, just for those that don't know, I'm the lead midwife for the East. So if there's anyone interested in getting sort of involved in different networks and bits and pieces, then do contact me. I'll try and put my chat. I see lots of members from Birmingham actually as well, and your contact lead is who's the midwife over there, just for your information really.
Yeah, so if any midwives or indeed health visitors have got any any questions or want to get involved in any networks, need nurses as well, just email, you know, reply to this invite and we can get a hold of you. And we've had lots and lots of positive comments in the chat, so thank you very much, Sally. And we're going to invite Sally to come back probably just after Christmas, probably November, that's before Christmas, January or February time, and because obviously then hopefully the study will have got started at some of the first 6 trusts. So thank you very much, everybody.